Thank you. Thank you. And also I would like to thank the organizers, especially Dr. Research and Omotto and others for the kind invitation and also for the introduction. So we'll be talking about diabetic kidney disease, something which is we need to pick up quite early, because as you can see, more than 30 to 40% of diabetes subjects have some level of kidney disease. So CKD is basically any affection of kidney structure or function which is present for more than 3 months. One, it can be the GFR can be below 60. The other are the other markers of kidney damage, which include albuminuria, which is ACR, something we need to screen more often. Urinary sediment abnormality, which we need to screen and which can be very done with the routine, easily done with the routine urine. Electrolyte abnormalities, structural abnormalities, as well as histological abnormalities, and also history of kidney transplant. So these are all evidences of markers of kidney damage. Now, where do we require to do a renal biopsy? Especially in patients, in diabetes patients, especially if they have nephrotic syndrome within 3 years of diagnosis without retinopathy, though there are now several studies suggesting that the prevalence of retinopathy is not that significant. We have published papers with regards to patients undergoing transplant without having developed diabetic retinopathy and proved diabetic kidney disease. Again, asymptomatic urinary abnormalities like hematuria or especially granular cast indicate glomerulonephritis. If diabetes subjects develop acute renal failure or sudden deterioration in kidney function, these are probable indications of renal biopsy. Why we need to pick up non-diabetic kidney disease in diabetes subjects is because of the fact that their progression may be slower. Again, there are many specific medications for their treatment, and probably the prognosis may be better in those cases as well. So this is a 57-year-old man with type 2 diabetes for 10 years, reasonably good A1C and blood pressure control, already on flozine, on telmisartan, as that is ARBs, as well as SGLT2 inhibitor. But the GFR, again something we need to stress, is calculating the eGFR, and that is 61. So if we see that in spite of the fact that the GFR is calculated, the ACR is not often evaluated, and most of the time we are picking up patients at stage 4 or stage 5 CKD or stage 3B CKD. So we need to be more proactive, because if we can institute treatments, we can prevent further progression to these later advanced stages. And we are all aware that the expenses associated with dialysis or transplant is phenomenal, especially for our population. So we need to prevent the progression to transplant or dialysis as well. Not only that, CKD is associated with increased cardiovascular risk. Most of the mortality in CKD patients are because of cardiovascular disease, whether it is cardiovascular event like MI or stroke or even heart failure as well, which is increased about 5-fold, or it can lead to dialysis, and again that is associated with its own set of complications as well. So all the guidelines recommend at least once a year screening with a GFR and an ACR. It's not mutually exclusive. Both have to be done together, both have to be done. And very importantly, we need to recheck the urine ACR is raised, we need to recheck it at least twice and reconfirm as well. So that's very important. And very important to emphasize that albuminuria is also associated with CVD risk as well. As we can see, the risk of albuminuria associated with CKD progression starts quite early, whereas the decline in GFR occurs pretty late. So albuminuria may be an early marker, though it's also a marker of cardiovascular disease as well. And as we can see, that albuminuria is associated with increased risk of CKD progression as well as cardiovascular disease as well.
and the degree of albuminuria also predicts these outcomes as well. So it's routinely recommended to assess GFR as well as urine ACR. We have 20-30% of our diabetic DKD patients who are non-albuminuric. That is also something we need to recognize, something which we may be missing. And there might be some treatment variations, especially in those patients who are non-albuminuric as well. So if you see with this patient with an ACR of 852, which is A3, which is severely increased, the patient is at moderately increased risk. However, if the patient was only calculated with a GFR of 61, he would have been in the this almost safe zone. So calculating a GFR as well as an ACR is essential to properly stage the CKD as well. So if you look at the ways we can prevent the progression of CKD, one is the ACARB, which looks into the hemodynamic aspect as well as the blood pressure. Then we have the metabolic control with regards to SGLT2 as well as the GLP-1. The SGLT2 also definitely has hemodynamic effect. And then we have the inflammation and fibrosis, which is associated with MR overactivation. Now we have data, especially for last 20 years, we have been using the ACE inhibitors and ARB. The data, especially with ARBs in type 2 diabetes, the IGT, the renal, the irbesartan, losartan, have been quite well established in terms of CKD progression. But after that, several trials, including the combination of ACE and ARB, have been found to be negative. Then came about the EMPA trial, after which there was dedicated CKD trial of frozen, which showed significant, almost 40% benefit in terms of heart renal outcome. This is across the board, whether it is DAPA, whether it is EMPA, and the first molecule which had the kidney data was the credence trial with canagliflozin. So almost all the studies showed about 30 to 40% decrease in progression to end-stage renal disease. And that slope of GFR decline, which is now so very well taught, is that the chronic slope is also decreased as well. So the MR overactivation can occur in a ligand-dependent fashion like aldosterone. We need to check the aldosterone axis, especially in patients who are resistant hypertension and diabetes. Again, it can be ligand-independent, and also it can be ligand-dependent on cortisol as well. And as we can see, the finerenone, which is a non-steroidal mineralocorticoid receptor antagonist, that actually prevents the progression by targeting the MR overactivation as well as decreasing inflammation and fibrosis. They may downregulate specific genes, especially the NPY, which is implicated in aldosterone secretion, as well as WNT, which is separately implicated in fibrosis as well. Now, the difference with the older aldosterone agonists, especially the spironolactone and epinephrine, is that they are bulkier molecules, they are highly selective, so their off-target effect like gynecomastia is much less. They have less penetration to the CNS, they have a shorter half-life, and they do not have any metabolites. So their risk of hyperkalemia, which is an important risk whenever we are using these agents, is also lower. So these are additional benefits. One is the specific high selectivity as well as short half-life leading to lower risk of hyperkalemia. So the early phase 2 studies were done showing that there was less hyperkalemia compared to spironolactone as well as reduction in albuminuria with comparable efficacy in epinephrine. Recently, there was a study which was published with regards to this molecule showing benefit in heart failure with moderately reduced or preserved ejection fraction as well. So that is another benefit which has been shown as well. Then there was phase 3 program primarily to look into the kidney aspect, especially with regards to patients with kidney failure and kidney disease progression as well as cardiovascular mortality. And it was almost encompassing the whole gamut of CKD patients, especially in diabetes. Mind you, these two studies were only conducted in patients with diabetes. So unlike the frozen series, only this finerenone data is limited to diabetes subjects. And then the viability analysis which took both these studies together. Mind you, both the trials show that the patients had well-controlled diabetes and well-controlled blood pressure. So it is on top of good glycemic control and good blood pressure control. The ACR was between 300 to 850. The GFR was between 40 to 60 in the two trials. Again, significant proportion of patients had cardiovascular disease as well. Most of the patients, 90% of patients were on inhibitors or TRBs. And if you look at the data, there was 14% reduction in CV composite outcome, including which was mainly driven by heart failure and CV death. And there was a 23% reduction in renal outcomes. And there it was 60% reduction in kidney failure and 20% reduction in end-stage renal disease. So this is, mind you, on top of ACE and ARBs as well. And as you can see, there was also reduction in all-cause and CV mortality as well. There was a reduction in albuminuria by 30%. And you can see that this is independent of background use of SGLT2 inhibitors. So on top of AC, ARBs and SGLT2, there was additional reduction in albuminuria. And we have all used this molecule. There is a significant reduction in albuminuria as well. And so the AD also recommends, especially in patients those who are in the macroalbuminuria stage, one should try to go for a 30% reduction in urine ACR for overall renal benefit. So this molecule is approved for end-stage renal disease, for GFR decline, prevention of GFR decline, for prevention of cardiovascular death and hospitalization for heart failure in CKD patients. So this is the third pillar coming in, the SGLT2, the RAS blockade, the mRNAs, and along with that, it is now also approved for heart failure prevention in CKD as well. So again, significant benefit with regards to hospitalization, and there was lowering of NT-proBNP as well. Mind you, whether we are going to have any difference in outcome with background SGLT2. So there was no difference in cardiovascular or renal outcomes, even with background use of SGLT2. Rather, when the combination, this again a later data which was published showing that with the use of combination of SGLT2 and non-steroidal mRNA, there was additional gain with regards to doubling of creatinine or end-stage renal disease of about 5 years and mortality gain of about 4 years. So a combination may be a better option. And again, this circulation data showing that a combination of SGLT2, GLP-1 and non-steroidal RNA provide the maximum benefit. As you can see, individually or combination of two agents compared to the three agents, whether it is MACE, whether it is heart failure, whether it is cardiovascular death, CKD progression or all-cause mortality, maximum benefit comes when all the three are used together. That is the non-steroidal mRNA, the SGLT2 inhibitor, as well as the GLP-1 receptor agonist. So this is probably the molecule which is coming up for the future. So whom should we initiate, especially when the GFR is more than 25 with a potassium less than 5? Starting dose is generally 10 milligram if the GFR is less than 60. If it is more than 60, you can start right away with 20 milligram. Again, the 5 important points, the 5 you must remember, the potassium has to be below 5. Withhold treatment if it is more than 5.5 and initiate only when the GFR is more than 25 or 1.5 benefit in terms of ASRD or heart failure hospitalization. Again, something which we have noticed in our clinical practice when we are using these molecules, just like ACE inhibitors, just like SGLT2 inhibitors, they also have an initial drop in GFR. But that is overall in the long term, the GFR decline slope is attenuated. So there is a long-term benefit, but short-term there can be an initial drop in GFR. That is something we need to be mindful as well. Hyperkalemia is increased somewhat, but that does not lead to discontinuation of therapy. Which group of patients we need to be careful, especially those who have an initial potassium more than 4.8, initial low GFR with hepatic impairment, and especially when they are co-administered with other potassium sparing agents as well. So there is CKD as well as CV efficacy. Even in patients who have a long duration of diabetes, even if they have a high HbA1c, even if the patients are on SGLT2 inhibitors or they are on background, they already have background in ACE. So now we have a holistic approach towards CKD. We have the age-old RAS blockade. We have now established the SGLT2 inhibitors as one of the pillars of management of CKD, whether it is diabetic or non-diabetic CKD. Finally known with regards to diabetic CKD now is established, especially when it is albumin. Here, when the ACR is more than 30 only, we are supposed to give it. And potentially after the flow trial with the GLP-1, that will be the fourth pillar of management of kidney disease, especially diabetic kidney disease. So this is something which has been now advocated by the KDIGO guidelines as well, the American Society of Nephrology, and even the ADA guidelines as well. So we are fast moving towards delaying or attenuating renal replacement therapy or renal transplant, at least delaying the progression of CKD for up to 10 to 15 years with newer molecules which we are having at our disposal. Thank you very much. Thank you for appreciating.